So again, my name is Paul Lavadera, one of the PGY2s, and I guess this is the first in the lecture series for Social EM. So I'll be doing it on health literacy. So introducing the topic with a story from the ER. So a patient comes into the ER for dry mouth, frequent urination after meals. They've been diagnosed with diabetes for about a year, have been recently prescribed insulin therapy. Upon questioning, they've been taking it 3 times a day with their meals, just as their doctor had prescribed, and they just feel off and discouraged and attribute these symptoms to the new insulin therapy. So now they have stopped taking their insulin for about 5 days, and they feel even worse, and they feel a little bit embarrassed. They don't want to go to their primary care doctor, and so they show up to the ER because they're not feeling very well. So as the ER doc, you probe further and find out that the patient has been administering the insulin after their meal, sometimes 15 to 30 minutes after the meal. And they're presenting with a glucose of 500, are in mild DKA, which is resolved in the ER. And in that moment, as the ER doc, you're tasked with the opportunity to have a discussion with your patient about what went wrong. So this case kind of highlights a few important things about adherence to medications, as they're prescribed, and how literacy in health and medicine can have a serious impact on the effectiveness of medical therapeutics. So what exactly is health literacy? I think it's kind of defined as a degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services in order to make appropriate health decisions. So it's not just about their education level, it's not just about their ability to be in an office and get to the office, but also to then process all of that to then make a decision for themselves. So to participate successfully in the healthcare system, it requires a constellation of skills, including reading, writing, calculating numbers, communicating with healthcare professionals, and then using health technology. So health, it's not just simply understanding your doctor's recommendations, but knowing how to get to a facility, how to know what facility to go to, how to register yourself once you're in the facility, verbalizing what went wrong and what's going wrong with you, and then expressing that to both the triage nurse and to a physician, and being able to know exactly how to tailor those conversations with those professionals. And so as you're fully aware, some of our patients may be interacting with the US healthcare system in Brooklyn for the first time in their lives, and they're bombarded with lots of questions and lots of instructions, which can be alienating, intimidating, and overwhelming. So one's level of health literacy is directly influenced by a few factors. So number one, you have your cultural and your social background. So your race, your ethnicity, your country of origin, the neighborhood that you grew up in, and their relatives' interactions with the healthcare system, in addition to also the education that they did receive. So, if cultural norms not match with the dominant values of the healthcare system, accessing health services, communicating with providers, and pursuing effective self-management can be pretty difficult, because such cultural mismatches, along with low socioeconomic levels and historic discrimination, as seen in Black, Brown, and immigrant communities, have contributed to disparities in health. So it's important to be aware that health literacy is also not a static attribute that defines someone, and it's not an individual's problem, and it's also a byproduct of the system level contributions that kind of dictate how that person is navigating through the healthcare system. So being aware of the fact that it's not an individual's attribute and it really is largely influenced by systems can help you to it can help to alleviate frustrations that you may feel towards a patient about, if they're non-adherent, or they're not able to describe their symptoms very well, or more recently, help to alleviate frustrations by understanding that lower health literacy, among many other factors, can contribute to vaccine hesitancy. So an estimated 90 million Americans have lower health literacy, including the populations listed here that are most vulnerable to it. So the burden of low health literacy does not lie on the individual, as I was saying, and healthcare organizations must also demonstrate and expand health literacy in order to reduce the demands placed on individuals. So this includes the responsibility of healthcare professionals to be aware of the dynamic social changes on subjects they may not have been taught in medical school or in residency, and to kind of make things easier for the patient to be able to communicate and navigate through their visit in the ER. So an example of this would be healthcare professionals who are resistant or unaware or resistant to learning and practicing the use of gender-affirming pronouns, which would improve their queer health literacy to better care for queer and trans patients. And if you aren't doing that, you could possibly kind of jeopardize the communication and trust that you have with patients. And that's going to kind of limit their ability to understand, process, and get through their ER visit or their outpatient visit. So it's just kind of one example of how we can kind of play a role in expanding the trust and communication with our patients. So according to the Partnership for Clear Health Communication, compared to those with proficient health literacy, adults with low health literacy experience 4 times higher healthcare costs, 6% more hospital visits, and 2-day longer hospital stays. So common adverse effects resulting from low health literacy include medication errors, low rates of treatment compliance, reduced use of preventive services, ineffective management of chronic conditions due to inadequate self-care skills, higher mortality, and then most relevant to us, unnecessary emergency room visits. So one study estimates the cost of limited health literacy to the nation's economy can be between $106 to $236 billion annually. And I think as ER docs, we're kind of not surprised by that when we have a patient who may have lower health literacy and we're doing lots of tests that may not be necessary, but it's part of the management of what you do that day. So with all this information in mind, it seems ER docs, especially in an urban setting, play a very curious role in identifying persons living with lower health literacy and then helping them to address this barrier to care. So we're face to face with persons who would benefit from a primary care doctor, obviously, but have found themselves in the ER. So what can we do? I believe our first role is identifying the persons with lower health literacy. So one method that's suggested by the Center for Healthcare Strategies and the National Action Plan to Improve Health Literacy is to implement something called Universal Precautions Approach. So just as we implement hand washing and sterility with procedures, these 2 action plans are suggesting that we assume that most patients have a difficult understanding with health information. And then once you know that, you can tailor your communication style to better communicate with your patients at the level that they need. So when 9 out of 10 English-speaking adults have less than proficient health literacy skills, it's an issue that affects everyone. And so several studies have shown that while interventions and materials that address health literacy have the greatest effect on individuals with lower health literacy, it also has it's been shown that it also is helpful with people who have higher health literacy. So it's not about dumbing down or speaking condescendingly to your patients. It's about assuming the patients require like a basic level of respect and patience when describing your reasoning for diagnostics, the potential results for the diagnostics, and the implications of those results. So, asking simple things, asking simple questions, putting things in ways in simple terms is going to be the way to do that, as opposed to like speaking in condescending terms. So there are formal tools to identify persons with lower health literacy, but I think in the ER setting, these are not going to be very helpful. You're not going to be like taking out those kind of tools and going through a long list of questions. So instead, I've kind of put up a few phrases or questions that you can bring up to kind of assess this when your intuition is telling you something. So the first is, medical terms are complicated and many people find them difficult to understand. Do you ever get help from others in reading prescription labels, completing insurance forms, or using health materials? Another question would be, a lot of people have trouble reading and remembering health information because it is difficult. Is this ever a problem for you? Another question I think is not as high yield, but like, what do you like to read? This could help because newspapers are generally at a 10th grade reading level and news magazines are at a 12th grade. But then I think one of the most helpful questions here in kind of addressing the current climate of vaccine hesitancy would be, what do you rely on most about, or where you get your health information? Everyone has a unique source: TV, radio, internet, friends, and family. So that way you're not making assumptions about the patient's background and how they've become hesitant of the vaccine. And you're better equipped to then empathize with the patient and inform them based on the health information sources that they're getting their information from. So if it really is a health literacy issue and not a political or other issue, this is one way that you can kind of identify that and then kind of make an intervention. So once you've developed an amazingly respectful and amiable rapport with your patients, as you always do with every single patient, that is, if your patient is open to this kind of relationship, you can move on to using clues to target and tailor your communication style. So intuition really plays a big role in this. So noticing a patient, like their facial cues, say you're talking to them and they're just kind of wide-eyed and they're just staring at you and, you know, shaking their head yes and saying yes to everything. And you're like, great, I know everything about this patient. Like, no, you should probably stop, pause, start from the beginning, ask questions to kind of tailor what's going on. So use that intuition to see. There's another method is when, this usually happens at the end of the visit, but you can, sometimes they take out little notes and you can see that their handwriting, you can kind of see what their level of handwriting is, or if they're writing their name, it may take longer than expected. So you can see that their writing skills are lower than proficient. And so in those situations, be aware of your own body and facial expressions and what you're doing to kind of increase the communication with your patient. So don't act rushed and create an open and warm environment with your patients. I know for me, I would usually like to sit down with my patient, but that's not possible. So I do like kind of lean down a little bit more to be face-to-face, because I do notice that that does make a difference. Coming in, closing the curtain, and just like making eye contact immediately, walking slowly to your patient. These are all really small things that make a huge difference when you're kind of trying to create this communication with your patient. So I'd argue that bedside manner is the most valuable tool that we can have as ER docs. And as I look around the room, I'm reminded of like plenty of us who are absolutely amazing at this and inspirational. So, you know, a lot of us are already amazing at doing this, but there's always room for improvement. So there are an array of different targeted and tailored communication techniques, but one of the most simple ones is using open-ended questions. So open-ended questions obviously will allow you to hear more than just yes or no from your patient in order to evaluate their ability to narrate and explain the story behind their health visit. So we all know that open-ended questions can sometimes result in a patient just kind of rambling in a direction that's not going to kind of inform us about our vital information that we need for our ER interventions and to move quickly to the next patient. But I think, you know, there's ways that you can do it. So examples of well-intentioned questions that may not generate a conversation would be, do you have any questions? Or can we answer a question for you today? They may just kind of say no, but if you can kind of frame it as, what questions do you have for me as your doctor today? You can remind them that you're their doctor. Patients sometimes forget that you're their doctor. Instead, you can and also ask, what questions can we answer for you today? So it's just kind of simple things that you can do, because if you ask a yes or no question with the do you have any questions, you're kind of already leading them into saying, I have something else to do. Say no so I can move on. Another of those tailored techniques is motivational interviewing. It's something that we probably learned in medical school during our psychiatry rotation. But this is kind of an effective counseling method that enhances motivation in the patient through the stages of change. So this approach meets the patient where they are in the pre-contemplation, contemplation, preparation, maintenance, and relapse stages, as you can see here. So essentially, you can kind of tailor the way that you speak to patients based on where they are on this And so I won't go into the specifics of this. This is something that you can kind of look up. You may have already known already, but I think some of the take-home points for me for it is that the studies have shown that your overall spirit of how you do the motivational interviewing plays a huge role in it. And so it's described as being collaborative, evocative, and honoring patient autonomy. That's kind of the largest portion of it. So if you're exhibiting and if you're speaking in a way that kind of respects their autonomy, it's going to help them to kind of garner that motivation and that empowerment to do something for themselves. And so, you know, you can kind of elucidate discrepancies between their current behavior and their future goals or values about themselves as a person. And so that's kind of the goal, is to kind of help them to explain to themselves the discrepancies that they're living with in their lives, and then kind of helping them to come to the conclusion that they might need to change, or they might want to continue with the habits that are healthier for them and what they consider to be healthier. So I've seen it done really well. I know I definitely need to improve in this. And after kind of researching this, it's something I want to do a little bit more. And it requires listening with empathy to understand the patient's motivations with the goal to empower them to support them in sustaining their life. So the method guides the patient to change their change rather than simply demanding or strongly advising a patient towards some objective healthy plan or healthy path that we think is best. And it shows that that's not how patients change. And they might say, okay, doc, like definitely like gonna change that. Like you already know, but for you, you feel like you've checked a box and you can move on, but you know deep down inside that that's not actually making a difference. So another technique is the Teachback method, which we all know about, and I'm sure many of us don't use because it does take a little bit of time. But I think there are subtle differences in how you initiate the Teachback method that could determine its success. So essentially, instead of, what did I just tell you? Can you repeat back to me the plan that we just made? You can try, I know your family is going to want to know about what we discussed today. What will you tell them when they ask about what happened? Or how can we help you with all the new information that we talked about today? So another tip would be at the beginning of the visit, you can kind of set the expectation at the end that you're going to ask about, you know, what happened today and what recommendations they're going to be given. So you can kind of help them to kind of have a more active listening approach during the visit. And I know that I've tried this, and sometimes it does take a while and you're sitting there and they're completely wrong. And then you're like, now do I stop and teach them everything again? Like it can be difficult, you know, but if you ask enough times and you see that your patients are always getting it wrong, that means that you're not communicating something well enough in the visit, or you're not tailoring your communication style well enough for the patient in order for them to kind of get that information and process it and understand it. So it can give you a kind of litmus as to like, how good are you at giving recommendations for patients? And you can kind of, you know, tailor your own strategies as you move along. So another thing is, similar to how you should not conflate disability, like developmental disability, with intellectual disability, you should also be aware how health literacy and limited English proficiency are related, though different. So more than 23 million Americans live with limited English proficiency, meaning they're not able to kind of speak or write English as proficiently as the general public. And while lack of proficiency in English can drive low health literacy, individuals with adequate health literacy just may be better in a language other than English. So practicing cultural competent care will help address this person's health literacy barriers. So people with lower English proficiency do have similar kind of problems as people with low health literacy when it comes to getting care. So they experience similar things like delay or denial of services, issues with medication management, underutilization of preventive services. But if this person is only having a limited English proficiency issue, then translation and interpretation services are recognized as the best practice in engaging with these people. And so to ensure that you have, so just make sure that you have easy access to Cyrocom at County or the interpretation services at UHB. So I know a lot of our Cyrocom apps have fallen off since last year, and I would encourage all of us to kind of try to get a login again and get it on, because calling can just be kind of difficult and takes a whole minute of time to get to the person. So making it easiest for yourself is going to make it less frustrating for both you and your patient, and to use it every time. It's easier when it's on the app. You literally just click it and it goes directly there. So in addition to ground level techniques that I kind of went over, there's also system level strategies implemented by larger healthcare systems that can directly combat and accommodate for lower health literacy issues. So one example is in Medi-Cal School of Public Health. They've created a guidebook in English, Spanish, and Chinese to help explain enrollment options and benefits to patients. Another one is how radio is used in Latin America to help improve health literacy by holding health hour segments. Another successful initiative is something called patient navigators, which you may have heard about, which are trusted individuals in the community who are hired by healthcare networks in order to help kind of coach in layman's terms patients and empower them to take control of their health and to navigate the healthcare delivery system. And so having trusted individuals, even nurses in our situations, we can utilize nurses to speak with patients and help to empower them if they're more, from the community or have a more kind of understanding of where the patient is coming from. And then finally, right here in New York, the NYC HHC system, we serve 103 million residents, 25% of whom have lower English proficiency. And we have signs in our bathrooms, signs in the hallways, kind of explaining the rights of patients in all the different languages, depending on which facility you're at, and patient-oriented resources based on those studies. So it's kind of got a lot of multilingual materials, gateway resources such as interpreters and client navigators. And so, you can see kind of Haitian Creole and English signs here at Kings County. So that's kind of it for the health literacy aspect, but I did wanted to highlight that this lecture is within the broader series of social EM. So social EM to me is listening to a community to gain knowledge and understanding of the factors that affect our patients' behaviors and health, which in turn help us to empathize with and provide better, more tailored care for our patients. So, here at Kings County, where there's a lot entrusted upon us to care for our patients in the clinical setting, and acknowledging that there are deficiencies in our cultural or social awareness of where our patients are coming from, and it's perfectly valid. And, we're coming from all places in the country. We may not necessarily be from the Brooklyn environment. We may not look and speak the same way as some of our patients. But I think that listening to patients, finding those moments where you connect and you have this level of comfort with a patient and you're having this eye contact and you just really feel like you're being heard and they feel like they're being heard in that situation is such an humbling experience that I've experienced in the last year. And it kind of exemplifies the magic created during those interactions in our field. So, if we can it requires a lot of intention to use the tools that I kind of went over today. And, there's a lot that we can learn from the role models here in our own residency, like from Smriti and Noah, Adrian, Kendall, or Gore, just to name a few obvious ones. But social EM doesn't necessarily need to be some big community project that you're breaking down big barriers to get patients to their care. It can look like just improving your bedside communication skills, your awareness of what barriers are limited in your patient's health potential, and kind of using the tools I've described to kind of empower them to be more self-sufficient in their health decisions. So this is not an easy task, and I commend all of you for taking on this challenge of becoming more socially aware and social justice oriented. So kind of the take-home point. So health literacy, it's not just basically someone's education level. It's their ability to obtain, communicate, process and understand what we're saying and what healthcare is telling them in order for them to make healthcare decisions. So for you to be able to communicate with your patient in the best way is going to help to kind of break down those barriers so that they can obtain all the information and to make those decisions. Lower health literacy is a very expensive byproduct of kind of the systems that we live in. And so anything that we can do to kind of help improve health literacy will also lower healthcare costs. And some of the techniques that I went over are listed here. And then kind of also just saying that social EM is here and is a field that we all are practicing every single day and that you can lean into to help to inspire you to be a better physician. Here are my citations, and that's it. Questions?
This was an excellent answer. Thank you. I just wanted to double remind everybody. For patients that have limited proficiency in English, please use Circumphone. In addition to the Circumphone, at Kings County, we have the green iPads. They're in triage. Usually 2 of them are in the PEDS asthma room. They're really easy. You just press a button and then somebody comes on a FaceTime with your patients. And also one thing that we're not good at is to use it again when you're discharging the patient. When you're discharging the patient, if you're discharging the patient, the discharge instructions is the most important part of that encounter. If you had used the Circumphone or the iPad for your entire visit, but you don't use it for the discharge instruction, you're basically, the patient might not come back. They might not, or they say yes, something that was limited. Obviously, somebody that doesn't speak any English, that is easy because you walk in, you start talking to them, and they're like, I don't even understand the word. And usually you go and grab the iPad or the Circumphone. The dangerous interactions are when the patient has limited knowledge of English and you start talking to them and they're nodding, or saying yes and no here and there, but they might not understand your discharge instructions. So please use these resources, even if it means that you're seeing one less patient in your shift. It's important.
Yeah, so just reiterating, there's the Sirocom at Kings, and then at UHB you have the green iPads in triage or in the PEDS ER. So to use those both in the beginning and end of your shift.
We also have sign language.
Perfect, and sign language as well.
And for patients who need sign language, if you call patients relation, they bring a specific iPad that stays at the bedside. That's a separate one just for those patients that stays at the bedside for their entire visit. So especially during the day, you can call patients relation and bring it and they leave it at the bedside.
Great.
I just wanted to reinforce something I think Paul kind of highlighted throughout his presentation is that this is intentional. This is I think sometimes we get lulled into thinking like some people are good at this, some people are this is natural to them. This is part of our job. It's something that you have to be intentional about. It's hard. This is probably one of the hardest parts of our job. When you have a shitty week and you're tired, you have to come in and you have to make connections with people. That's part of what we do. It's probably one of the most difficult things we have to do every single day. But to do your job well, it's part of it. So making that eye contact, making sure that your patient understands. And some days you're going to be bad at it. Some days we're all bad at it. But I think it's important to think of it that way. And one other thing I like to add, just in terms of making connections with people, I like to use touch as well. I mean, obviously, making sure the patient's comfortable with that, but putting your hand on their shoulder or shaking their hand, I think that goes a long way as a physician. I feel like for a year and change there, it was a little more difficult to do that, but I've been trying to do it a little more, and it's been feeling good. So try to add that to your repertoire. I think patients appreciate it.
I make jokes with them, like if they're like saying something that is funny and they know that it's funny, like laugh with them. Don't be like so far away from them that they feel that we don't have any like real connection with them. So especially I live in the neighborhood, sometimes I see them around and they're like, we see you around. It's like, yeah, likely. And we just like talk a little bit about it. So that is also something that you can do to make the connection more powerful.
I'd love to make you happier in your job.
Thank you, G.
I mean, patients want this education. They're coming there, they not only just want you to give them a prescription, They want to know what's wrong with them. They want to know what they can do to help make themselves better. And it's worth that time. And if you don't do it, like you said on your thing, they bounce back, and that costs more money. But we're not interested in money. They come back sicker often. They didn't take their antibiotics the right way. They didn't get them at all, or they didn't understand, you know, not to eat salt or whatever it was. And so they want to do that, and you really have to make things simple. Not because they're dumber than us, they're not. A lot of them are more street smart than I will ever be, or better on their computers. But because they want to explain things in their language. And, you know, so you're going to have to keep it simple in language they understand. They don't understand like things like metabolisms maybe, and all kinds of fancy terms and Krebs cycle. They're not going to understand that. So you have to keep it simple. And one of the things that I've seen people do is rather than give a few simple instructions and then explain them, people just print out, 5 pages worth of stuff and give it to them. I've seen that time and time again. And I won't read 5 pages of stuff. I won't. And, so simple things. And the ones who want it, sure, then you can print it out, or you can tell them how to print it out or what website to find it on. But for a lot of the patients, they just want to know what they need to do. Another technique I find that's useful sometimes is to draw things, make simple diagrams. For example, with sciatica, I'll do that a lot. Draw and show the nerve being pressed. It doesn't take very long. But it's a very important thing to make sure that you communicate the important things of what they need to know. And they want it. Patients like that.
Thank you, Paul.
Thank you.